Our next speaker is Donald Mabbitt. Dr. Mabbott is a senior scientist at the Research Institute at the Hospital for Sick Children and an associate professor of psychology at the University of Toronto, evaluating brain-behavior relations in normal and impaired neurodevelopment using cognitive data and quantitative MRI methods. Dr. Mabbott has been seminal in our understanding of the long-term effects of radiation therapy during childhood on late cognitive function. And he's recently begun exciting new work to find ways to foster brain repair following radiation injury in children treated for brain tumors, including the use of physical exercise and drugs that stimulate the growth of new brain cells. Dr. Mabbott.
I was born in 1967, almost, not quite 50 years ago. And as you can see, I'm really holding dearly on to that almost. That was my attempt at folksy humor to warm the audience up to me at the beginning of my talk. My adolescent teenage son said to me in words of encouragement about this talk before I left, he said, "Dad, don't worry, the audience is laughing at you, not with you." I was hoping there would be a session on the adolescent brain this morning so I could understand the kid. Where was I? 50 years, 1967. The year that I was born, of 1,000 babies born in the United States, 23 died. Today, that number is 6. You can see on the image there on my right, your left, you know the one, the staggering decreases in infant mortality and neonatal mortality that have happened in the last 50 years. In the 1960s, if your child was diagnosed with cancer, they had a 33% chance of survival. Today, that chance is over 80%. And you'll see, in terms of the new challenges we face, on the other side, the right side of the slide, the dramatic decreases in cancer mortality and the related increases in averted deaths that we've seen. The extraordinary advances that we've seen in the treatment of pediatric health and pediatric illnesses and injury are seen again and again across most pediatric disorders. Congenital heart disease, traumatic brain injury, the list goes on and on. With few exceptions, increased survival is the norm in pediatric health and in pediatric diseases and injuries. There's been a revolution in my lifetime in the care of children. In fact, I would say in our lifetimes, I look around and I'm not the oldest guy in the room yet. The majority of children are cured of their diseases or saved from their injury and go on and live into adulthood. But, and you knew that but was coming, but there are storm clouds behind that great silver lining. Survivors of pediatric disease and illness go on to experience significant chronic medical and mental health conditions. These chronic conditions and disabilities have long-term personal, societal, and economic costs, and we need to do something about them. 63% of childhood cancer survivors have some type of medical ongoing condition. In fact, children with brain tumors, the patients that I serve, are particularly at risk. And I'm going to focus on these patients in the rest of my talk, and I'm going to focus on their cognitive and psychological effects that they experience because I'm a psychologist. So children with cancer, with malignant brain tumors, are treated with surgery, and you see the picture of the surgery, and chemotherapy and radiation. And this is a life-saving regime, multimodal approach to treating cancer. But the tumor, the surgery, the radiation, and the chemotherapy all damage the developing brain. And that leaves children with physical, neurologic, psychologic, and social deficits. So in real terms, survivors of brain tumors, at least the cohorts that I've seen, don't finish high school, are not independent as adults, live with their parents, don't complete college, are socially isolated, and have few meaningful romantic relationships. The radiation that's delivered to cure brain tumors has an impact on the brain. Probably it's the most toxic of the therapies. And on the bottom of the slide, you'll see some work that we've recently done looking at the impact of radiation dose and field and neurological complications on intellectual outcome, on intelligence. And so on the bottom of the slide, you see our, on the x-axis, IQ, intelligence quotient, and on the y-axis, time since diagnosis. And you'll see the three dark lines, and those are all longitudinal curves looking at declining IQ over the years following diagnosis for a malignant brain tumor, in this case medulloblastoma. This is the story for most of the kids. Now, there have been some advances with new risk stratification regimes that we see in the treatment of pediatric brain tumors. We've been able to start reducing intensity. So if a child gets reduced dose radiation to the cranial air cavity, cranial spinal radiation, and a very tight focused boost to their radiation to the tumor bed, and that's the group in the light red line there, you're seeing now some stable intellectual outcomes for this group. This group still has other difficulties that I'm not going into today. So when I started my job 17 years ago, I worked primarily as a clinician, and I would meet with families. I would do neuropsychological assessments of children treated for brain tumors. And they all had difficulties. All the kids had challenges. And parents would ask me, what can I expect for my child? What can I do to help them to get better? What can I do to help them in their learning? And I would say to them, well, I can't predict the future, but I know very few patients who've completed high school. We can go to the schools and we can help develop special education programs. We can help develop accommodations. But I really don't know of any approaches, any therapies that can help repair the brain or restore cognitive function. I think all that's changed. I think with the advent of precision medicine and regenerative medicine, topics that we're going to hear about later today, I think we're in a new era. We're in the next revolution of pediatric healthcare. In this next era, I think there are going to be many advances that are exciting. I want to focus on one, actually stemming out of Dr. Korfis's talk this morning, and actually will be followed up by Dr. Jocelyn's talk, looking at brain plasticity. Getting new cells to grow into tissues is becoming a reality. Getting new brain cells to grow, something that we just didn't think was possible for a long time, is no longer far-fetched. Near here, we have pediatric trials of stem cell transplant. The work of my colleague Frida Miller and her husband David Kaplan that I highlight down at the bottom there in Cell has shown that we can probably trigger endogenous processes in the brain to activate neural stem cells for brain repair. In fact, as an example of some of the second repurposing that Dr. Guttmacher talked about this morning, I currently have a clinical trial using metformin, a diabetes drug, to foster brain repair and cognitive restoration in childhood survivors of cancer treated with radiation, based on the basic work that Frida and Paul Franklin, who is Sheena's husband, and others have done, showing that this drug activates the stem cell niche. But I'm not going to talk about that trial to you today. Today, I want to focus on another way in which we can enhance plasticity in the brain. And that is by harnessing the normal developmental processes, the processes that Dr. Korfis talked about, to help repair the brain in children with a brain injury. By targeting what kids think and what kids do, I think we can enhance their innate plasticity in their own brains and start focusing on repair and restoration in our population who have some kind of injury. My daughter, Adriana, is a smart kid, and she has a learning disability. Or, as she likes to call it, a learning difference. It's just that I think differently, Dad, is what she says to me. Whatever she says, the girl can't spell. And she has a hard time with written work because getting her ideas down and communicating them in a written fashion is very challenging for her. She's in grade 8 now, and she was given an assignment by her teacher to write a story and read it to the class. As you can imagine, this would be a challenging task for her, and historically it has been. But instead of taking a piece of paper and a pencil or a pen and writing the story, she took out her iPod and she dictated the story. The day came for the individuals in the class to share the story, and her teacher, Mr. Morrison, said, "Okay, who wants to share your story today?" And 5 hands went up. And one of them was my daughter's, Adriana's. And he said, "Okay, Adriana, you tell your story." And she got up, and she read this story that went on for 10 minutes. And the teacher and her classmates just stood gape-mouthed at the level of detail, the character development, and the plot of this story. And when she was finished, the room was quiet. And then the class broke into applause, which I think is pretty cool. But the cooler thing, and maybe this is more a reflection on me, is then when Mr. Morrison said, "Okay, who's next? Okay, who else wants to tell their story today? Carter, you tell your story." And Carter said, "No thanks, I'm not going to follow that performance." In fact, nobody in the room wanted to follow her performance. By changing the way she did things and thought about things, she was able to overcome her disability or her learning difference. Now you may say, "Oh, that's a nice story about your daughter." And really, assistive technology these days is nothing new. And any parent who has a child knows that the learning brain is very plastic. But I use it as an illustration to make the point that I think if we start changing the paradigm about how we consider treating these secondary injuries that children experience, if we start thinking about how we can engage children as active agents, I think there's many new possibilities and much hope. But you're probably not saying it now after Dr. Korfis's talk, but you may have been saying it before, and you won't be saying it after Sheena's talk. How do we know that thinking and doing actually changes the brain? Well, plasticity in the brain is seen after some type of task. So you heard all about the myelin changes. There's actually trials of motor learning, and there's trials of even memory training highlighted in the Nature Neuroscience review there that show that the brain changes following these interventions. It grows. Michelle Monge, our moderator today, did an elegant experiment, and you see it highlighted there, and you see the picture there, showing that if you turn neurons on and activate them, that glial cells grow. So there is this whole body of work on plasticity out there, but what we don't know yet is how to harness that work in order to repair and heal the brain. There was actually an NIH working group just a few years ago, and that was the resulting paper in Brain highlighting, we know this body of work, but there are so few clinical trials looking at brain plasticity as a therapeutic modality for treating brain repair. And that brings me to exercise. So exercise, we've long known from animal models, activates the stem cell niche. It activates neural cells to grow into healthy new neurons and myelin cells. We know from human trials that in healthy and pathological aging, it enhances brain growth and improves cognitive function. We know that in healthy children, exercise is important for enhancing cognition and brain growth. But surprisingly, there are very, very few studies that have applied exercise to some kind of brain injury model. And there's no studies that have applied it to a pediatric injury model. So I said, what if we set up an exercise program for the patients that I serve, the patients with brain tumors who have survived that illness but now have an injury from their treatment? What are the possibilities? What happens if we change these kids, if we help them change what they think and how they do? Will that have an impact on their brains? So we developed the Kid Fit exercise trial. And this was a trial, essentially it's gym class for kids with brain tumors. Over the last 3.5, 4 years, we would go out into community schools, we would rent the gym, and we would run a gym class for our brain tumor survivors, which is no small feat because most of these kids are actually normally marginalized from physical activity because of some of their neurological deficits. And they would do games, they would run, they would do sports, they would do floor hockey, a common pastime in Canada. And they were supervised by a physiotherapist and by a kinesiologist. They wore a heart rate monitor, and before and after the exercise program, we monitored their fitness levels, we did advanced neuroimaging, and we did psychological assessment with them. And if you look on the top panel, we found some striking results. So the top panel is diffusion tensor imaging, again, the imaging modality that Dr. Korfus referenced. The core blue areas are those areas of white matter that we looked at, and those red areas that you see across all the axial planes of the brain are areas of increased structure of white matter following exercise. And if you look on the panel to the side there, all those little green and red dots represent each kid pre and post training, and you can see the upward changes in fractional anisotropy, a measure of brain structure, of white matter structure. This was a striking finding for us. This was a very robust finding. We also saw a 10% increase in the size of the hippocampus. And we saw increases in the speed with which these children think. Now, white matter damage is the main phenotype of radiation injury. Decreases in speed of processing are what we typically see following radiation injury in these children. We saw increased white matter and we saw increased speed of thinking. Quite remarkable from my perspective. Now, I'm sure you can see many limitations with this work. We're currently working to publish it, and it's in revision, and so I know the limitations because the reviewers are very good at telling us the limitations. But I'm excited that we may no longer have to accept cognitive morbidity as a cost for cure of brain tumors. In fact, I'm more excited that I think we can apply this type of methodology to other brain insults, in fact, to other diseases and injuries, obesity that we heard about this morning. I think more and more we're seeing exercise medicine clinics as part of our healthcare organizations. More and more we're realizing that education system and the healthcare system are both in the same business for children, and that's building better brains and making more healthy brains. And more, I think that we are coming to realize that we need to treat the secondary injuries and the secondary illnesses that children have acquired as a cost of the cure of their primary disorder in the same way. We need to come up with clinical trials and protocols to treat these as separate insults and injuries on their own. When I meet with families now, 17 years later, I say something very different than what I did before. I still say your child has a significant injury, they will have difficulties, but I think there's something we can do about it. I think we can make a difference. You need to stimulate their brain. You need to take them to the museum. You need to read to them. You need to do games with them. And you need to get them to do exercise. Lots of exercise. Thank you.